The third of 4 webinars that i+solutions is organizing on the topic of supply chain solutions. We're very happy that you could join us. My name is Annette Denis. I'm the host of the webinar. Today's topic is creating innovative end-to-end visibility, a case study with eLMIS Medexis in Burundi. In a minute, I will hand over the microphone to our speaker, but first we have a few household messages. First of all, the PDF of this presentation will be shared with every one of you after the meeting. The webinar will also be recorded for training purposes, but your video image will not show on the recording, just so you know that. During the presentation, you will all be muted. If you have any questions, please ask them to Anouk van Praag, who is the co-host today, in the chat room, but just to her, please. All questions will be collected and answered after the presentation. We hope that we'll have enough time to cover all of them, but if not, then all remaining questions will be answered by email after the presentation. We hope that our internet connections remain stable. A few of us are in the Netherlands, others are in Burundi, so we could have a hiccup somewhere down the line. If that should happen, please bear with us. We'll try to solve it as soon as possible. Our speaker today is Landry Medegan. He's country representative of Burundi for i+solutions. Landry has been with i+solutions for 10 years, working in several different roles. And since 2017, he is working, like I said, as a country representative for Burundi, strengthening the Burundian supply chain for sexual and reproductive health and nutrition products, and the introduction of an eLMIS are among his tasks. He is assisted today by Fulgence Munezero, who is a pharmacist by training, but who has been working as a technical advisor of supply chain management since 3 years for i+solutions. And Fulgence is also a Medexis super user. So I wish you a very pleasant time with us and an interesting time. And I now would like to give the word to our CEO, Ed Munchen, who is also moderating this webinar. To you, Ed.
Yeah, thank you, Annette. Welcome, everybody. Good afternoon. This is the 3rd series in our webinar. Today we zoom in on end-to-end visibility. It's a topic very close to my heart because we believe we can improve supply chains with innovative solutions. And we all know that data are not accurate and timely, and that's the start to optimize the supply chain. And especially in the last mile, that's a challenge. So I'd like to give the word to Landry. I will get back to you at the end of the presentation and open the floor for questions. So Landry, over to you.
Thank you, Ed, and good afternoon, good morning to each of you. Today, we're going to talk about i+solutions Medexis story. So we will first talk about the needs, and then how we design the system, and then offer you, give you a demo, a quick demo of the system, and then talk about the way forward and question and answer later. Okay. Next slide, please. Yes, how the idea of Medexis was born. That's our start point here. So next slide, please. Actually here, before we talk about details here, is that we have identified 2 main issues in total, you know. And the first issue was about data and information visibility and accuracy issue, you know, and then the second one is about processes and tools issues, you know. So we're going to talk about the first one, and this first one about the data and information visibility and accuracy issues. Here you can see that, you know, imagine that a minister or somebody is asking you how many quantity of quinine, for example, or how many quantity of bed nets, just an example, you know, is available then at X facility, Y, Z, health districts or provinces, you know. So it's always difficult to give them an aggregated inventory. So here that results in lack of real-time visibility of the supply chain information. And then another one we saw as well is about some of the logistic data are available, on the paper-based eLMIS, paper-based LMIS, but not accurate. And that results then on in this lack of reliable data, and then some issues with data accuracy. And another one we saw as an issue is that, in Burundi, at district level, you need as a district team member, health district team member, to fill in 12 tools, management tools, for a program. And then at health facility level, we're talking about 15 different tools, and all these need to be filled for each of the different health programs. So then here, what is that result actually in data? Some data are missing and are not reported in the paper process. And then another and the last, not least but last issue we encountered as well is about the central level, which is always not able to see, the real quantity at the last mile level. I mean, for example, at district level or health facilities level, when, for example, they are actually, they distribute products. So right now, the Kamebu, the central medical store, distributes product till district level. And then beyond that, they don't have any other visibility about how those products are consumed. And then they don't even receive then back some reports about consumption and logistics information. So that's what results then in lack of end-to-end view, especially the ability to view the situation in real time at last mile. Next, please. So about the second component, about the processes and tools, the issues we saw here is, for example, that is about management tools. Those management tools are not standardized, and then each of the program has its own management tools, and requirements. And then here we're talking about seven different programs then in Burundi, and which with 7 different supply chains as well. So then that results actually in lack of robust processes and systems to manage storage and distribution throughout the entire supply chain. And then the actual quantity available and usable actually of products, at health facility and district levels are not also always, considered or taken into account when actually doing the forecasting and quantification exercise. So this results here in poor forecasting and quantification as well, And then the paper-based, there are various paper-based systems in country. And those paper-based actually systems, what they do is that they are different. They all have their own format, and request and requirements as well. And then, so each of those programs has their reporting format, as I always said. And then also some of the donors have that different format as well. And is all, at the end of the day, the same people, then the same responsible pharmacist who has to fill in all this different information. So then, so they are paper-based system widely used in country. And then another last issue we've seen also is that, for example, the channel software, as you all know, is only used as the district pharmacy level. And then this channel is not connected to any other health facility, nor to any programs, and also not to the central level as well. So that results actually in different solutions, different electronic solutions, which are there, but not standardized, you know, and yet versatile, and also then are not simple to work with. Next slide. So why then a new eLMIS system? So we took it from the existing system, and then we noticed there that they are not always user-friendly, and some of them are expensive as well, as you know, and then not always owned by the country, because at the end of the day, our aim is that a country own its own data, you know, because it's about data, it's about information. It's important that there is that ownership by the country. And then those systems also do not have always the key feature you need actually to manage a proper eLMIS in place, you know. And then those systems are not integrated with DHIS2 as well. So here that results in no correlation between clinical data and logistical data. And then that's also result also in a poor customer satisfaction rate at central medical store. And the rate actually is about 30%. So that means that I'm coming to you with a list of 100 products, and then you give me only 30. So I have to go source the other 70% somewhere else. So that creates also an issue there. And then there is also a long procurement lead time at the central medical store level. Around average is about 367 days. And then all these together result then into a recurrent stock out, overstock, and expiries. Next slide, please. Yeah, here actually, what's good is that we designed Medexis in 2018, and then from bottom up approach, you know, bottom up to top approach. And then here with our technological partner in Portugal, who is translating actually the requirements into the system. And then so you can see here that the system can be used by various people, various supply chain people. So meaning the health facilities, the health districts, central medical store, different programs, and even donors, you know, who can access the system and then retrieve information they may need for the program. So next slide, please. Yes, here now I will give the word to my colleague Fulgence, who will then give us a quick demo. Thank you.
Okay, thank you, Landry.
Welcome.
Thank you. You see? Do you see the screen?
Yes, Fulgence.
Okay, now I want to begin by showing you the dashboard of this Medexis. Here in the dashboard, you see that you can see the stock out for some health facilities, and you can filter by program. For example, the program of nutritional product from Yanit. The system will show you exactly where there is a stock out. Here I see CDS Kisimbawaga. Also, the system will show you automatically the overstockage. You can see for that program where there are the overstockage. You can manage and transfer those stock out, those overstock in the other health facilities in order to avoid the preemption. Also, in the dashboard, you can see the stock on hand by different programs, and you can see the details. For example, nutritional product by product, you can see the stock on hand today. In the dashboard also, we can see the key performance indicators. Also, you can filter by programs, and you can select start date and end date, and the system will show you some key performance indicators. You can see here some key performance indicators. Okay, after this dashboard, I can show you a different menu of Medexis. You can see here data entry, when you can create requisition, validate requisition, order allocation, picking and packing, create shipment, manage consignment, consumption in the health facility, stock write-off, transfer stock, inter-facility transfer, inventory checkup, inventory setting suggestion, and receive LPO. This receive LPO is where the commodity enter into the health facility by another supply. For example, private pharmacy, not the central medical, not Kamebo, for example, here in Burundi. You can see another menu, important menu, which is some different reports. Here I can show you, for example, the inventory report. The inventory report where you can filter by program. For example, the program of Medexis. You can see here even the warehouse, the location, batch number, the commodity, stock on hand, stock allocated, and the value of the stock. I can show you also another report which is important. For example, inventory aggregations, where the Minister of Health, for example, wants to see the quantity of quinine in a certain province of Burundi or a certain district. You can filter by province and also by district and also by program. For example, Medexis. And the system will show you the aggregation inventory. You can see here stock on hand and the stock value of that the commodity for that program. Another report is the eLMIS report. The eLMIS report also you can filter by program. And you can select the start date and the end date. The system will show you the opening balance, receipt, transfer in, transfer out, write-off, consumption, closing balance, dates of stock out, and they will calculate automatically the IMC. Okay, there are other functions for settings which are available for admins only. I can show you a small example in the data entry where a CDS can make a requisition, and the requisition will go directly into to the level of district. I can show you an example of CDS GitHub and select a program of a nutritional product. I can select one product, for example, plant peanuts. The quantity needed. Okay, I click on add, and after I submit for approval. Okay, you see here it is now in the district level, and the district level we have to validate. I think Landry now can continue with the presentation. Thank you.
Thank you, Fulgence. Annette, next slide, please. Thank you very much. Sorry, let's talk about our experience and intervention about Medexis in country. So here, next slide, please. So as you see, we experienced, then we pilot Medexis actually in 2019 in Burundi for 14 products in total. So 9 family planning product, 1 post-abortion care product, and 4 nutrition products. And then we started with the central medical store, because this is where they are taking the product from. And then we covered 13 districts out of 47 in total in country. And then 133 health facilities out of 1,336 health facilities in total in country. And then about a number of patients, each of the health facilities of our area of interventions then has an average of 9,000 people actually, per health facility. Next, please. Yes, here you can see about our approach. What we did actually was to strengthen the capacity, the capability of the responsible pharmacist, and then the district team as well, and then the one actually manipulating the product, the one managing the product. And then therefore we have developed a user guide and training modules, and then to help health workers actually to record their data in the system. And then we trained 18 master trainers in total who trained then thereafter 197 users in total. So now we have all those people who really master the system, and then who record the data on time. And then we have developed a monitoring and supervision framework as well to make sure that we monitor performance here, and then assist where needed. And then we developed also different tools. I mean, then inventory and stock management reporting tools and different dashboards, so that in the system, when you go to the reporting area, as Fulgence has shown, you can retrieve some reports actually, and then filter and sign, and then even put it somewhere actually in your file, and then so that you have the visibility, and then you have monitoring. And then we coached and supervised the district executive team in those districts, and then 240 healthcare providers in total. Next slide, please. Yes, here about the conclusion and way forward, we're going to talk about the results we achieved. And next slide, please, Annette. So about the results is that availability has increased while using Medexis. As you can see, that availability rate here has been measured by 10 products, and mainly reproductive health products. And then so that you can see that we went from a baseline of 85%, then and end with 99% in total. Next slide, please. Stock out have been reduced substantially here while using Medexis as well. And the difference here is that we measure that rate actually by health facilities. So you can see that from the start, 94% of those health facilities were experiencing stockout situation, and then we managed to bring them down to 8% at the end of December. Yeah, next please. Expiries here have reduced significantly, you know, while using Medexis. Here is that, you know, because of you have the visibility through the entire supply chain, then you can see always the already the product which are about to expire, you know, and then take the corrective action as well. So that here we managed to reduce all these expiries, which cost a lot of money actually. So we reduce it by 85%. Yeah, at the end of the day. Yeah, thank you. Next, please. And then about overstock. The overstock here has been reduced slightly. We wanted to show here the result we had because, you know, from the baseline, you can see that we managed to increase that number of health, rate of health facilities actually with no overstock. And well, then we experience also another issue. Actually, due to a low utilization of female condoms in country, then we had that product overstock. And then that's why, the reason as to why you can see that the overstock has been reduced slightly. Otherwise, here what we do is that we redeploy products actually where needed to make sure that the health facility have optimum products. So next slide, please. Yeah, about lesson learned during the implementation, we learned a lot actually here. And so you can see that they are divided in three components: technical, behavioral, and skills. About the technical, the use of another computer, dedicated computer for pharmacy is essential, is needed. Because what we saw in most of the health facilities is that they do have one single computer, but when the chief nursing is attending some meetings, he goes with that computer, and the responsive pharmacist then experience delays in recording the data into the system. And then the data are now recorded accurately. As you know, the paper-based tool, you can, a 3 can always turn into 8, you know, sometimes. And so now is that because of the system, the data are correct, are accurate, and recorded timely, actually. And then another thing we haven't foreseen is about that data validation. And that has been, we have then introduced a corrective action here and at district level, so that the district executive team then sit together and then analyze and validate the data before they send it over to the central level. And then about connectivity. Internet connectivity is essential, as you know, for Medexis. And then even if we have that possibility of having, the system has been developed actually, you know, to allow 2G capabilities. So that means that we're really low band at community level. Then people are able actually to record their data. So and also when internet is not available, then the data can be stored and then also synchronized later. And then internet connectivity was an issue as well, where internet wasn't. People were going actually in average of 5 to 18 kilometers to seek for connectivity. So that show here how they wanted to record their data on time as well. And then about behavioral lesson learned here. We've seen we haven't seen a lot of resistance to change as we expected. So that was a good one because everyone was motivated, really high motivated actually, and to want to not be, you know, they want to be the best in class as well. So everyone was trying his best actually to record on time his data into the system. And the system also contributes to a significant reduction in time for health workers, actually bringing the total requisition lead time actually from 15 days down to 3 hours, you know, so that is a substantial gain they can then give to clinical aspects. And then the about skills is that we've seen some health workers here, you know, for example, there is a 55 years old health worker, really motivated, but who has never touched a keyboard before, you know, for a computer. He has never worked with a computer before. So that was a challenge. What we did is that together with the chief nursing, and we reached an agreement where then he will continue using the paper-based, you know, and then the chief nursing will assist him actually to record what has been put on paper then into the system, and it went well. So that was one of the examples I wanted to give. So next, please, Annette. Yes. Now I think I will give the word back to the moderator, and thank you very much.
Well, thank you, Landry and Fulgence, for your concise presentation. I think the results look pretty impressive, the stockouts going down and expiries. So I cannot imagine you're ready yet. So what are the next steps in this program?
Okay. Yeah, the next steps here is that, thank you, Ed. The project is still ongoing, and then we are working actually right now in consolidating the results, the ownership, and accountability with health workers, you know, of those health workers, so that they can do it on their own, actually, without our intervention, you know. And then on the request also of the immunization national program, the system will be expanded to the vaccines as of end of October. So this is in discussion with UNICEF. And now, so this is good because we started first with the health, reproductive health, and then we added on request of the Ministry of Health, the nutrition, and now vaccine will be added as well. And in parallel, the MOH of Burundi was inspired actually by the initiative, and then has decided to adopt one national single and integrated eLMIS for all commodities in country. And then in this regard, several workshops have been held as part of the selection process of that eLMIS, and the MOH is now finalizing the administrative process. This is what I want to, thank you.
Okay.
Yeah.
Nice. By the way, if you want to ask a question, you can do it live, or you can put it in the chat. We have a few in the chat already. Maybe I can invite Jasper Kladwijk to unmute and ask your question. It's difficult to hear you, Jasper. I can barely hear you. I think we have an issue with your mic. We cannot hear you, Jasper, but I can read your question if you're okay. So your question is, the health facility, can they also order through the system if they have a lack of products from other health facilities who have overstock? Which is, I think, quite an interesting question. I don't know the answer, to be honest. Landry or Fulgence, do you know that? Whether a health facility itself can order from another health facility who has excess of stock?
Oh, okay. Actually, they can order when they can order, and they can even transfer. They can do some inter-facility transfer as well of stock. This is also possible, you know. And then all monitored by the responsible pharmacist at district level, you know, so that he knows what is happening, and then the system does record all those transactions as well.
Yeah, yeah. If we do a full demo, it takes about half an hour to 45 minutes, and you go through all these steps. So we couldn't do it in this webinar, but if there's an interest, we can always organize that, of course. I see Lander, you have a question. Can we unmute Lander or do it yourself?
Hey, if you can hear me, I can do it myself.
Yeah,
can you hear
perfect.
me?
Yeah, perfect.
Now I have to look up my first question because it's a time ago. But the most important one is, I think, the drugs which were shown by Landry, and thanks for the very clear presentation, and Fulgens. The drugs in the system, do they have to be all part of established programs? Because I see that you have a pull-down menu for a program, but is it also applicable for stock like regular Kamebu stock?
Yes, it's also possible then to configure actually for a Kamebu own stock, and then so that the system can track to the last mile actually, and and then report back based on the origin of that product. Also, yeah, that's possible. And also, for example, as we talk about the customer satisfaction rate, which was really low, you know, about 30%. If, for example, a district managed to find product somewhere, like a donated product, you know, that system, the system then will record it with different supply paths, you know, using an LPO, we call it. And so that at the end of the day, we can see exactly which product comes from where. And then even if they are in the same common basket, at the end of the day, you can trace them back to the origin of them, of the product. Yeah.
Yeah, great. What the other question I had was, because I saw all kind of data linked to the commodities and the drugs, but I didn't see expiration dates of certain batches. Is that included or not?
Yes, the expiration date actually is systematically included. So the system should always capture this date. So what we do is that we make sure that the health facility does enter all this information. And then we have seen that there was sometimes an issue, you know. So what we have developed as well is that we have this G1 code, GS1 code, this global standard 1 code, for example, or GTIN, they call it. Yeah, those code bar, yeah, where you can, by scanning the product, for example, at the entry of the supply path, then from the central level, you can already retrieve all this expiry date, you know, batch number, and then there will always, you select a product, for example, that will be associated directly till then throughout the entire supply chain, so that at the end, the health worker doesn't need to key in this information in the system. Yeah.
Thank you. Thank you very much.
Yeah, you're welcome.
Yeah, thank you, Lander, for asking. We have somebody called Desiree who has 2 questions. Maybe you like to ask them yourself, Desiree? No, not being unmuted. Well, the first question is, do district level have visibility to lower levels? So can they see the commodity data at the lower level and validate it? Oh, yes. You're live, Desiree. Sorry.
Yes, exactly. The district level has the visibility of the health facilities, can also have access to inventory and see what the quantity which is in every health facility for that district. Thank you.
Yes, okay. And it's important to mention here that that district will only see all health facilities in his area.
Yes.
You know? Yeah.
Yes. Yes.
Yeah. So there's a whole authorization module. Yeah. Hi, Desiree. Hello? Please ask what you would like to ask.
Yes. I want to ask you also if the first of all, I would like to thank very, very much Randy for the very good presentation about the eLMIS. I want to ask, Landry, if the tool has the financial component, as you may know, a lobbyist supply chain should be, of course, patient-centered, data-driven, of course, the reliable data, and also business-oriented as well. So I want to ask you if the tool also have the financial component. Thank you very much.
Okay, thank you, Desiree. When we enter the product, actually, from beginning in the supply path, we attach the cost, you know, of that product to it as well, you know, so that there is the system can track the budget available, and then the consumption of that budget, how, and so that you monitor the consumption of that budget as well. And then what's good we have done also is that we try to adhere to the specific supply path of a supply chain of Burundi, you know, whereby there is a certain percentage the district adds to the product once it's at their level, you know, and then the health facilities also do the same at their level to the patient, you know, is 10 and 5% as well. So we have then configured the system to always then make sure that the product at the end of the day, the stock which is available, for example, do have a value, a nominated value you can monitor. And then,
And maybe if there's interest, please let us know, but we could organize a full demo, because you have seen in less than 10% of what's possible, and there's so much behind it. So if there's interest, we will more than happy to organize, let's say, a 30, 45-minute full demo with Fulgence and Landry. So let us know. We have 2 more questions in the chat. One from Jasper, who still has difficulty with his mic, so I will read it. Question to Landry. So this is a pilot. So what's next? Especially interested in what other products can be included next to SRHR products and nutrition.
Okay, so the next is to add the immunizations to the current intervention, and we will do that as of end of October now. So we are well prepared already for that. So we will do that in 2 different steps. First step is that to make sure that we harmonize then, you know, together with the program, for example, the requisition lead time, and then the min and max, you know, because it's different supply chains and with different requirements in Burundi. And then we want to make sure that the system is more or less harmonized. And then from there, we give first the visibility about the management of those products, those vaccines. And then thereafter, we're in the second component, which will be later next year. And then we will, we have prepared also a module, a vaccine module. And this vaccine module was configured actually based on the Gavi requirements, you know, and whereby you need to have a certain features. And so we have done this. And so we expect that in by that time, that will completely finalize it, and then we'll be able to experience it somewhere as well, you know, because we need to test that component. I mean the management of the cold chain part only, you know. So this is how we want to what will happen in next coming days and weeks actually. Yeah.
Okay. Landry, thank you very much. We're running out of time, but one last final remark, question from Quirijn. What is the key to success of the pilot in Burundi?
Yeah, this is,
just a few words. We're running out of time.
Yeah, the key to success actually is, I think, is the ownership, and then the accountability of the health workers. And then we've seen that and then involve them also from the beginning. So they're really part of that, and they're really happy about the change they're also seeing. And they wanted us to cover all commodities, but we were not, we didn't have that mandate yet. So Yeah, I think that's what I can add. Maybe Fulgence has something to add as well, or Ed or someone else. Yeah.
Fulgence, one last remark. What's the success? Why is it a success?
The success is, for example, in the health facilities where we are now, the manager of program can ask you, what is the quantity of femidome do you have in that district? And now we are able to show him very quickly the quantity of that product.
Yeah.
Yeah.
Okay, thank you very much. I'm afraid we have to close the webinar, so I switch back to Annette, but thank you, Fulgence and Landry and your team for doing the great work there in Burundi.
Thank you very much.
Thank you, Ed, and thanks to Landry and Fulgence for the presentation. Like Ed said, we're running out of time. I would just like to draw your attention to the last webinar in our series, which is the blockchain pilot in Nigeria. The webinar is taking place on the 22nd of October at 3 o'clock. You can register for that. You can follow us on LinkedIn. We'll be doing some communication around it. So there you'll find also the way to register. And last but not least, like I said, we will share the presentation with you. If you have any questions for Landry, as you can see on the last page of the presentation, you'll find his email address. So you can ask all of his questions, and we will also collect your answer with regards to the demo that Ed proposed. So, well, looking forward to seeing you there or at the blockchain webinar. And thank you very much for joining us. I wish you a very pleasant afternoon and evening.
Thank you, Annette.
Thank you.
Bye.